Okay, our next speaker is Dr. Joelle Simpson. She's a pediatric emergency medicine physician and chief of emergency medicine at Children's National Hospital. Dr. Simpson was recently elected to the board of directors for the American Academy of Pediatrics as a board member at large. She's one of the 4 lead principal investigators of the Pediatric Pandemic Network. Dr. Simpson will be describing the HRSA Pediatric Pandemic Network and its role in preparing the nation for the needs of children in the next disaster and global health threat.
Thank you for having me, and it's truly an honor to sit before you in sort of to describe the reality of what Dr. Batshaw just discussed in terms of the evolution of advocating for the Pediatric Pandemic Network and now seeing its reality come to fruition. So to jump into things, I really want to also thank Dr. Dixon for sort of laying a little bit of the landscape of the urgency behind which we use to advocate for the development of the Pediatric Pandemic Network. First, I want to share that I have no disclosures. But the key need, just to reiterate a lot of what Dr. Dixon said, but really to formalize how we approached the federal government in terms of why this was urgent and why this was important to have right now, is that, as she discussed, almost 25% of the US population comprises of children under the age of 18 that have those unique healthcare needs that span both the developmental, medical, and social needs. 30 million children seek emergency department care every year, and a majority of those actually seek care outside of our pediatric facilities that are well-groomed and customized to caring for children, whether it be how we measure their weight, the equipment that we use, and certainly the best practices that we employ to provide their care. Outside of pediatric emergency departments, the awareness of our families when seeking in-crisis care for their children is not as, sometimes is often taken for granted for those of us that are so accustomed to the pediatric environment. And so those threats of not being as ready outside of the pediatric facilities was certainly dire, particularly during the pandemic. We understand that there have been persistent disparities, and historically, even prior to the pandemic, the inequities in pediatric care that have parallels to general care of our population is well recognized and exacerbated during this recent crisis. COVID-19, as Dr. Batshaw mentioned, also had initially the tone that it was most critical for older adults, and the question of how it impacted children was really up for debate in some scenarios. But us in the pediatric, within the pediatric world certainly knew that the families that were presenting to our emergency departments and the unique diagnosis of the conditions such as MISC, and certainly even the evolution of the pandemic in terms of the long-term effects on the lifetime of children is still up for question and still requires investigation in order to better meet those, the domains of the disaster cycle as Dr. Dixon discussed. So what has been our legacy in terms of improving not just the response to a crisis and disaster, but the everyday readiness? And we've talked about the progress that has been made nationwide in addressing children every day, as well as in disasters. And starting as far back as the Emergency Medical Services for Children's program, which was touched upon, and I will talk about in significant detail, also funded by HRSA, that has been built around the concept of every state's focus on being ready for children in all stages of healthcare, whether it be pre-hospital, certainly in the emergency department, hospital, and even to long-term care and back to the communities. And that has been important in terms of the effort around that federally funded program on a state-by-state basis. And then we move forward to the 2021-2022 merger of our 10 hospitals that have come together to build the Pediatric Pandemic Network. So I'll talk about each of the efforts around everyday and disaster readiness moving forward. With the Pediatric Pandemic Network, we were very early set on establishing a mission and vision that would help us, as Dr. Dixon defined in the 3 priorities: capacity, collaborate, and to guide our science. So in collaboration with the nation's children's hospitals and their communities, the network will coordinate, prepare, and enable high-quality, equitable research, pediatric-based care in emergencies, disasters, and pandemics. And I really want to highlight that we continue to talk about emergencies, disasters, and pandemics. Even though the name is a pediatric pandemic network, we are all encompassing in terms of a focus on those everyday emergencies as well as the larger scale disaster threats. And then our vision is to improve the health outcomes of children and the resiliency of children, families, and communities impacted by emergencies, disasters, and pandemics. And that is the crux and foundation of how we have started to work in the past 9 months together and have plans for the next many years to make an impact in pediatric health. So around the goals of our PPN are to increase particularly children's hospitals' partnerships with local, state, regional, and national emergency preparedness systems. And this is important. It talks to the coordination among us, as we saw during the pandemic, that many of the children's hospitals sort of naturally reached out to each other in terms of shared protocols, approaches to operationalizing issues with supply chain demands, as well as even staffing operations to best serve the needs of children. Also important to that was collaborating with our community partners. And Dr. Dixon talked about the environments in which we already know children exist. It was quite evident during the pandemic that the importance of working with our school systems and certainly with our the employment infrastructure when kids are at home and families still need to work and have an income, how do we better prepare our communities to deal with that pivot from where the usual environments of where children are cared for? Improving the pediatric emergency readiness of healthcare systems, including hospital and pre-hospital systems, is also important. As we mentioned, 80% plus of kids that seek emergency care, or families that seek care for their kids in emergency departments, happen outside of children's hospitals. All the more urgent for the practices that children's hospitals have been able to have as best practice for emergency care be shared among our partners that also care for children in emergencies and crises. And then we realized the emergence of telehealth systems that served as a conduit to improve access across the country. And so one of our calls to action within the PPN has been to increase the capacity of telehealth systems to address the unique needs of children and families. And then, of course, to accelerate the real-time dissemination of research-informed disaster care. And it was really important as we had the support of the National Academy of Sciences to launch that symposium on disaster science in the early stages of building our PPN, and that helped us really talk about what are the key areas of research that we need to explore to better meet the needs of children in emergencies, pandemics, and disasters. So here are our hub hospitals for the Pediatric Pandemic Network, spanning across the country in states including Kentucky, Alabama, certainly here in Washington, D.C., Ohio, Seattle, California, and Illinois, which has been really nice to work with a breadth of children's hospitals that have different environments that they practice in terms of the regional differences around the populations that they serve, rural, urban, north, south, east, and west. And that has really strengthened with the diversity of perspectives of our different challenges in those different environments. I also want to draw your attention to the lower right corner, some icons that speak to some of the foundational networks around disaster preparedness that have been integrated and work collaboratively with the Pediatric Pandemic Network. I mentioned the Emergency Medical Services for Children's program, and specifically the EMSC Improvement and Innovation Center. This is also the entity I mentioned, funded by HRSA, that has been in existence for many years and has had really cross-cutting pillars of advocacy, research, knowledge management, quality improvement, collaboratives, analytics, and web-based and value-based care around really some core focus areas that overlap significantly with the priorities of the Pediatric Pandemic Network. And that is to think about the spectrum of care within which children receive their services, whether it be pre-hospital, hospital, trauma, and certainly disaster preparedness. The foundation of the EMSC program is really to work with the strengths and to work with the challenges, to address the challenges of each state's sort of unique environment as it cares for children. So that state-based program certainly is at the table when we discuss the work that we want to build upon within the Pediatric Pandemic Network. Also, in 2019, ASPR funded the Pediatric Disaster Care Centers of Excellence, and we're proud to have the PIs of each of these grants well connected to the PPN to help establish how do we build on each other's work, certainly not compete, but continue to collaborate to extend the science that has already started to develop among these disaster centers of excellence. Most recently funded is the G7, the first ICON that is mostly in the southeastern states. And the approach here among the disaster centers of excellence, whether it be the Western Coast, the Region 5, which refers to the Region 5 of FEMA states, these three grants have worked to establish regional coordination of pediatric health systems and disaster networks to better serve the needs of children. So you marry the state-based work that has been done with EMSC, the regional-based work that's done with the Pediatric Disaster Centers of Excellence, and then you map that work geographically across the country, and we have a very robust, coordinated group of subject matter experts that are now thinking about the issues that Dr. Dixon highlighted and Dr. Batshaw noted that we went to Congress for to advocate for the work of the PPN. Here you see highlighted not just the hub hospitals for the PPN, but then the ASPR Centers of Excellence, the work that has already been established by the Emergency Medical Services for Children's program, and then other key partners such as the American Academy of Pediatrics, the American College of Emergency Physicians, all of whom have been at the table in terms of discussing the issues we're talking about today. So we came together as a merger of 10 hospitals last year, and we were at a meeting recently where we talked about the fact that truly the merger of our 10 occurred about 9 months ago. And as a pediatrician, we think about a 9-month-old entity. We're really proud of what we've accomplished so far, and we've set up an organizational structure that is the merger of the grant proposals of each of those 5 hospitals and is as follows. We have a concept of certainly our funder and our core hubs that meet the network operational, that is the network operational team guiding the work of the PPN. But then a lot of our work is also divided into service cores as well as core functional domains. And on the far left, just sort of talking about the service cores, these are the areas that have been married from the work that has been done for those other funded entities and the strengths of the PPN subject matter experts that are under the PPN, including things such as we know the importance of having analytics in order to sort of figure out what is the data and how does it need to be sliced and diced in order to tell the story, to develop research studies and to continue to advocate. We have community engagement, health equity, even a legal domain as we talk about the infrastructure of telehealth as a new entity and how do we work with that in responding to disasters. And then across to the middle row, we have our core everyday domains that are around some of the priorities as established in the 5 priorities of the PPN, including telehealth, work in the pre-hospital space, infectious disease, and so forth. And then we have disaster management. So core to disaster management, everyday emergencies and pandemics. We talk about the same issues, some of which Dr. Dixon brought us, such as capacity and capability. How do we think about the needs of CBRN, which is our chemical, biologic, radiological threats, as well as the concerns around reunification, specifically with the challenges that pertains to kids and so forth. So this gives you a sense of how we've been organized, all of these domains collaborate, and I'll give you an example of one of the domains that we are quite proud of that is making quite a bit of progress. So here's a sample of how our education domain is organized. We have been able to focus on what are the outcomes of our domain that's important to advance the work of the PPN. So we know that we want to be able to publish, to be able to share our best practices in terms of how do we educate our pipeline of investigators or clinicians that are interested in disaster science. Certainly, we provide expert consultation within the PPN, and we hope to expand that even beyond the PPN group. Resource enhancement, micro learning development, and macro learning development. And we've produced quite a few modules, and we have a lot more in the pipeline to be able to better build curricula, as well as inform the population about research outcomes from our domains into the public space. So this is just an example of some of the work that we do within a domain. Our core activities are to provide training, to support, to encourage the collaboration, as I mentioned, instead of competition, share those best practices efficiently and effectively, not just within the pediatric community, but throughout healthcare and certainly within our broader population. And on the foundation of that is to continue to promote equity, inclusion, and cultural relevance. Where we are right now is that we've merged our 10 hospitals, and we call them fondly 1.0, and the name of our 5 here, where Children's National is the lead site, is called the NPPCC, National Pediatric Pandemic Coordinating Center. We've engaged over 100 subject matter experts, and you think about our 9 months and being able to build on the foundation of the other funded networks federally, that has been an awesome experience to continue to push each other on the ideas that we've put forth for the PPN. We have some core project teams, we have a National Infectious Disease Advisory Board, and then we continue to build collaboratives around quality improvement efforts and other coordinations of disaster management experts in order to be ready for the next threat. This year, we know that we're boiling the ocean as we have come together. So we have prioritized among many of our objectives 4 core areas to focus on in the 2022-2023 priorities. That includes, and that's who the focus of the talks after me will be highlighting, a focus on infectious disease and disease outbreaks, emergency and disaster management. We know that it's important to focus on mental health and behavioral health, and certainly health equity and community engagement as our core areas of investment, particularly for this year. I'm excited for you to have the other speakers speak in a little bit more depth about the PPN, particularly around these areas. And we'll wrap up there so I don't sort of steal some of their thunder. And hopefully I've been able to whet your appetite in the excitement building around the Pediatric Pandemic Network. I want to thank our HRSA colleagues, many of whom are in the audience, for the funding to make this a reality. And also want to share with you our website, should you have any more curiosity about what we do, pedspandemicnetwork.org. Thank you.